Thank you very much, everyone. It's a great pleasure to be here. I haven't been to one of these recently. I think the last one was Oslo. So you've had a break from me, and I'm now back, whether you like it or not. And I've got in the show business world, the graveyard slot, which means I'm either got to keep you awake or I've got to put you to sleep quickly. So I was asked to talk about recent research, and I thought what I'd focus on is what's changing in how we manage dystonia, which is probably more important for most of the people here, and what's happened in the last few years and what directions we might be going in. So I appreciate we're all running a little bit late, so I promise definitely not to go over time. If I can save us a bit of time, I will as well. So I thought I'd just show that Europe rules when it comes to dystonia and dystonia neurologists. There are many neurologists from various European countries who were involved in the history of dystonia, starting from this was a case clearly of dystonia in 1897 by a Spanish neurologist who originally described them. Then we had a couple of German neurologists who described some of the genetic forms of dystonia, the more severe ones. We drift into Poland here with Edmond Flatteau, who did a lot of work. And then Hertz in the 1940s was the first person to bring video cinematography into the study of dystonia, which has been very important because still pictures don't show you what dystonia does. You have to see them moving. And then, of course, you've heard about David Marsden, who some of us have worked with. He was my supervisor when I did my research as a student, who started to describe and link that the various forms of the focal dystonia, the neck, the hand, the voice, may well be linked to those people who've got much more severe childhood onset dystonia. And there are probably similar processes going on in the brain affecting how we control movement. And then we finally let the Americans have a little bit into this when Stanley Farn, who was the other doyen, David Marsden and Stanley Farn, probably put dystonia on the map. And actually they drew it back from being thought of being a total psychiatric disease into being a neurological disease, but with psychological effects, as you heard about, with non-motor ones. So this is a sort of history of European neurologists, which I think history is always good, but we better look forward now. You hear lots about dystonia, and the only thing I really want to say about this is dystonia still remains a clinical diagnosis. It's what you see and what we as neurologists hope we get right. There is no diagnostic test for dystonia. Even the gene tests aren't diagnostic because we know lots of people with genetic forms of dystonia have the bad gene and never develop dystonia in their lives. So it's not a test to diagnose it, it's just a test to say they've got the gene. And we use it to help us sometimes understand some of the forms of dystonia. And basically what happens is when you perform a movement, too many muscles get involved and they produce the tremor, the postures, the spasms. It goes away when you go to sleep. I always think we should be learning more from what's going on there, but probably being asleep all your life is not going to be the answer. And it can affect many parts of the body as well. So from the neck, the eyes, the larynx, and at a very simple level, it's just when I perform a movement, I've got a nice little program which tells me to straighten my arm and relax the muscle that bends it. And these processes somehow go wrong in dystonia, so too many muscles get involved and they fight each other, and that's what dystonia is. So what sort of problem is it? I was talking earlier to someone else about how common it is, and this is something we've been thinking about for decades. One thing is all the studies looking at how common dystonia is clearly are an underestimate of the real thing because we're talking about lots of different conditions which present in different ways with dystonia. We're talking from very severe ones to very mild ones. Some of the mild ones never meet medics. But we sat down a few years ago with the Dystonia Society and people in the UK and the epidemiologists, and we came up with the thought that if you look at all forms of dystonia, so it's a broad description, in the UK, so we're talking 60 million people, there's probably at least 90,000 people with dystonia. Interestingly, most people have what we call a focal dystonia, affect one part of the body, so it's the neck, the torticollis, or the writer's cramp, the blepharospasm, but they have a very disproportionate effect on people's lives. And there have been studies we did in the turn of the century and more recent ones looking at groups of people with either cervical dystonia, with laryngeal dystonia, with blepharospasm, and it became clear that in many of the individuals, when they filled in quality of life scales, they felt as disabled as people with Parkinson's, multiple sclerosis, and it had a big effect. And a lot of that effect came from the fact that they felt stigmatized, they had anxiety, it affected their mood. And you can see that across different types of dystonia, from generalized ones all through to focal ones. So getting the diagnosis right is very important, and I'm sure there are lots of people in this room who spend a lot of time getting the diagnosis right. And it's helpful for many reasons, but first of all, to know what you have. Once you know what you have, people can be clear with you about what's going to happen, what's not going to happen. And it all boils down to describing what you see. So that's what we do as neurologists. We want to know when it starts, which part of the body it affects, does it come and go, or is it there all the time? How does it vary? Stress makes dystonia worse in almost everybody. Whether it's just dystonia on its own, or whether it's got other neurological features. And then we start thinking about what might be causing it. Is there actually something which we can see on a scan wrong with the nervous system, or like for most people with dystonia, they have normal brain scans. It's something about the way these circuits work rather than being damaged to the circuits. Is there a genetic cause? And then there's some much rarer forms which are due to either treatable forms of dystonia, which aren't common, I'm sorry to say. There's a rare form of genetic dystonia called dopa-responsive dystonia, which responds incredibly well in low doses to the drug we use in Parkinson's, levodopa. And then there's some other conditions like Wilson's disease where they can't, the copper which they take in their diet, all food has copper, gets badly processed and gets deposited in the brain and the liver. If you pick that up early, it's treatable. So, and the myoclonus dystonia, which you've just heard about very nicely then. I mean, I think as Anne said, alcohol is probably not the answer. We know they respond to it and we can learn from that, but there are other drugs which can sometimes help. So what's been happening new? Well, management covers everything from diagnosing to treating, and I appreciate most of you in the room are more interested in treating, but getting the diagnosis right. And there was an interesting paper from the Netherlands a couple of years ago where they were in a center where they saw severe, complex, difficult forms of dystonia, and they were looking at the fact of do gene tests help you at all? And so they did an interesting study where they took 61 cases and they had 2 dystonia experts, and they compared how they gave them all their records, their scans, and they said, what do you think the diagnosis is? And then they said, would you like to do 1 and 2 genetic tests? And if so, what would you do? And then they said, what's the diagnosis? And they compared the result of that with doing a whole gene panel of over 90 genes which can cause different types of dystonia, and say what was more effective. And what they found was actually the pickup rate, I mean, it's still quite low, was double when you did the gene panel as opposed to having your 2 experts looking at it. And it was cheaper because you just did it once and it gave the answer. Now, we're still talking small numbers of complex people, but I think the most telling thing, there were 3 new diagnoses which the 2 experts hadn't thought were necessarily likely, and they were all treatable forms of dystonia. Again, rare, and probably doesn't apply to most people in this room, unfortunately. But I think this is important that modern technology can help us get the answer in some of the cases more quickly. You see, in the literature in neurology, you get these fantastic flow diagrams like this. This is how we treat dystonia. This was a very nice review by Kailash Bhatia, who's an eminent dystonia neurologist in London, well, in the world. And it's got these fantastic tables and makes it seem like we're really good at treating dystonia. The answer is we're not really good. These are the possible options, and most of them involve things you've all heard about. Drugs, which don't work very well. Botulinum toxin, which can be very helpful, is probably the most common and probably the best common treatment. Then there are very rare forms of dystonia which have very specific treatment. And then we talk about DBS. So everything you've heard, and I think what this table sort of says is things haven't changed much in recent years. So how do we treat dystonia? Well, in most cases, we treat the symptoms. We don't have cures. Deep brain stimulation is not a cure. It's just a more complex technological way of treating the symptoms of abnormal movements. And how we treat them really much depends how much the body is involved, how severe it is. So for most people in this room who've had a focal dystonia, the neck, the eyes, the hand, they'll have had botulinum toxin. And that probably still is the best treatment for that. For people with more severe dystonia where you can't give botulinum toxin to all the muscles because they'll get poisoned with the toxin, drugs are used more often in childhood onset. And then there are different ways of delivering the drugs into the spinal canal. And then for more severe forms, people think about deep brain stimulation. So we all know botulinum toxin, one of the most poisonous toxins in the world, and here we are giving it to you in small doses. And all it does, in effect, is this is the end of a nerve, and that nerve releases chemical messages onto the muscle, and it makes the muscle contract. So what happens is there's too much muscle contraction in dystonia, so all the injection does is the chemical messengers or neurotransmitters, in this case called acetylcholine, which is released and makes your muscle contract, is held in little packages called vesicles, and there are proteins which are involved in releasing these chemical messengers, and the toxin goes in there and disrupts this system. And it leads to temporary weakness for weeks or months, and then gradually these nerve terminals resprout and grow again. It's a bit like roots in your garden plants, and the spasms come back again. So it produces a temporary weakness, but it is an effective treatment. And what's new? Well, there are terrible names, lots of new forms of botulinum toxin. Now, most things in the pharmaceutical world, what tends to happen, if something's successful, all the other drug companies will make something similar and give it a different name. And for most of these cases, these are probably no better than what's around. Just to highlight, there's one newer one which is suggested might last longer, because the problem with botulinum toxin is it wears off and you have to go back to clinic in 3 months or so. If you had one which lasted longer, that might be better. So it's used for the neck, for the cervical dystonia, it's used for blepharospasm, laryngeal dystonia, and some of the dystonias affecting the arms, the face, and occasionally the tongue. What about drugs? Well, it's complex slides, but what this is really showing is that this was a study 2 years ago of 2,000 cases of dystonia. It was an international study, and they were looking, how have they been treated? And the things really to say is, these are the different types of dystonia. So focal dystonia, blue is botulinum toxin, and the orange and red are drugs. And then this one down here just shows what drugs. And the drugs that have been used by most of them are those that have been around for 20, 30, or 40 years. Almost nothing new in that, I'm afraid. And then from a very good group, not too far from here, Jean-Pierre Lin's group did a study looking at childhood dystonia. I think it was a couple of 100 cases looking at drugs. And the most important thing was how many of them had had a drug. And the most common used drug was baclofen. And I think a lot of this is because they have complex cases. This is a muscle relaxant, often used in spasticity, but can help for dystonia. And then the red column by it is how many of them got side effects. Baclofen was probably the best because there's much more blue than there is red. When it comes to an old-fashioned drug called trihexyphenidyl, which has been used a lot in that, almost the same number of people got side effects as got the drug. So that's the problem with a lot of these drugs. They can work, particularly in severe dystonia, but they can produce side effects. So drugs mainly are used for people with more severe dystonia. Generalized dystonia are often the childhood ones, and for some reason children seem to tolerate better than we do as adults. For most people with an adult onset focal dystonia, drugs aren't going to be the answer. Sometimes they help with the symptoms, but it's not great, and that's why most of you will be sent to botulinum toxin clinics rather than start on medication. And there are groups, these are the anticholinergics, which are the ones which produce a lot of side effects. There's a little bit of evidence. Most of these have no trial evidence to actually say how well they work. A little bit of evidence for baclofen, and then a lot of the other drugs that sometimes are tried because there's a few reports in the neurological paper saying this worked for us on this patient. So what's new? Well, what happens in conditions like dystonia where there's not a huge amount of drug industry interest is people say, what other neurology drugs are out there, and perhaps we can try them. And so there have been in the last 3-4 years some papers of drugs which might help people with dystonia. So gabapentin, which is a drug used in epilepsy and in pain, was thought to help to some extent with childhood dystonia. There's another drugs which actually reduce the amount of the chemical messenger dopamine in your brain systems. There's a new one which may be useful. And lots of other ones. There was a very unusual one of a drug called clonidine in blepharospasm, which a small study, and no one else has reproduced this. It would be marvelous to have a drug for blepharospasm, but I think there's some consternation that this may not be a very real effect. And probably the one that was probably the most useful was an anti-epileptic drug in the condition you've just heard about, which is myoclonus dystonia. So not a huge amount has changed. Baclofen, in particularly more severe cases, and this is something, again, Jean-Pierre Lin uses a bit more for children, can be infused into the spinal canal, so it gets nearer to the nervous system and has an effect on these bad messages causing dystonia coming down the spine can be useful, but obviously it's more invasive. And sometimes people can get infections of this, which can be worrying. And so there are quite a lot of complications. It has to be done in very well-selected cases by very experienced centres. Cannabis. Now, before you all go out running and start growing it in your greenhouses, it's probably the same in the rest of Europe, but it's become a huge issue in the UK, mainly because there are cases of using certain forms of cannabis for intractable epilepsy, which probably works for some. The difficulty is that it's, in the UK, still an illegal drug. The other difficulty is for dystonia, there's only been 2 very small trials which probably, because of the numbers, weren't very well designed, and they use different types of cannabinoids, which were just the different active components in cannabis, and in both of those it didn't seem to make much difference. Cannabis can relax people, and certainly we've all seen patients who've taken cannabis and it's relaxed them and it's had effect on the dystonic spasms. Whether it's doing anything more than that, we don't know, and certainly in the UK we're not allowed to prescribe it for dystonia, because there is no trial evidence. And other countries, it's a bit more available. Canada, Netherlands, it's obviously more available. I'm hoping my son, who's traveling through the Netherlands, won't bring too much back with him. Well, he's not for himself, anyway. So what about physical approaches? Well, there's been quite a literature about physiotherapy, retraining, biofeedback. This has been around. There have only been 2 trials of physiotherapy for cervical dystonia, so both of which sadly didn't give a positive result. There was one in Scotland, which is the most recent one, in 2015. There are other ways for people with limb dystonia to try and retrain their hands or to restrain them and to use what we call immobilisation. And much of this work has actually been done in musicians. Professional musicians or people who do a lot of things often get dystonia of the part of the body they use very frequently to produce that music. So in violinists, it's the fingers. In pianists, it's the fingers. People who do woodwind can get dystonia affecting their lips. So we see focal task-specific dystonia more commonly than you'd expect by chance happening in people who are repetitively doing the same thing. So overuse seems to be a role. And some of the studies doing suggest that the areas of the brain represented by those, rather than being clear-cut, representing where the lips are, where the fingers are, tend to get a bit more blurred. You can map these out using these magnetic techniques that Anne spoke about. And is there a way that training could bring some clarity back to that bit of the brain, almost unlearning those bad effects? And there's some suggestion there's been some benefit. There was an interesting study of pianists. Now, everything that goes up here were things that were thought to benefit the dystonia. And I think perhaps the interesting, I'm not sure what this tells us, that this bar here was saying had the greatest positive effect on the pianist dystonia, and that bar was changing your piano teacher. So, not sure what that tells us. Maybe it's different forms of piano, but I mean, and it may be that different piano teachers have different ways of practicing their instruments. It may be, there's a logical way why that's happened, or maybe some piano teachers are just bad for you. I don't know, but it's a difficult area. You heard a bit about the psychiatric features, and this is something which has become more of people have been more aware, and you heard about this big study of almost 500 subjects, and again, reiterating things that had been found 10 years ago, that even in focal dystonia, there's a much higher level of social anxiety, normal anxiety, depression in these groups, and in certain ones, there's also pain as well. Cervical dystonia can be painful, we realize that. Musicians had a different sort of psychological profile, and that may be, again, associated, because to be a professional anything, you have to have certain character traits more prominent. You're performing, you're practicing religiously. I think perhaps interesting, and something that's always crossed some of our minds as neurologists, what would happen if you actually did something simple, like cognitive behavioral therapy in patients with focal dystonia? Would that have a beneficial effect? You could try and ameliorate some of these psychological effects, and would that spin off onto the physical effects as well? Never been done. So what about trying to stimulate the brain in different ways? I should warn you, one of these pictures is not a real study. I'll leave it up to you to work out which one it is. And there are various ways you can study the brain using magnetic stimulation, which Anne was talking about. You can also treat the brain using magnetic stimulation, and there's been a number of studies using transcranial magnetic stimulation. And what happens is, in dystonia, when you produce a movement, there are lots of checks and balances all the way from where your brain initiates that movement all the way down to where your spine sends a message to the muscle. And we have, all the way through that process, we have inhibition, things telling your pathways, calm down, don't get too many muscles involved. And it's what we call inhibition. And people can show, I mean, rather like, a bit like the blink reflex Anne was talking about, there are reflexes at the level of the spine, the level of the brainstem, at the level of the cortex, which generally damp down this signal command. And in people with dystonia, they're abnormal. There's not enough inhibition. And what magnetic stimulation can do is upregulate that inhibition. And it's been shown people with writer's cramp and other things, temporarily, after having magnetic stimulation to that area of the brain, it reduces their dystonia. The problem is that lasts for about 10 to 40 minutes. So unless you have some incredible hat, maybe rather like this guy in the middle, where you're constantly stimulated, or we've got some very clever engineers, which may be the way forward, because if you think how technology has developed just in mobile technology, what phones were like 20 years ago and what they're like now, and what they can do, maybe that is something that can be done. But we also don't know what continuous magnetic stimulation of the brain, what sort of side effects that may produce. And there's another one called transcranial current stimulation, which is being studied, which can do similar things. Now, we all know about deep brain stimulation, so I'm not going to spend too long. It is a useful treatment. It's a useful treatment, particularly for dystonias, what we call isolated dystonia. So dystonia is the only thing. They're not associated with other conditions which you sometimes see. It's quite good for some of the childhood onset generalized genetic forms like DYT1, for limb dystonia. Myoclonus dystonia responds quite well. And interestingly, probably better than the alcohol, both the myoclonus and the dystonia get better. Alcohol's good for the myoclonus, not so good for the dystonia, as Anne said. And over the years, people have been looking at different forms of dystonia and saying, will DBS help with this? And the answer is, in carefully selected cases, people who are very resistant to botulinum toxin or have developed antibodies to it, it can help. It's particularly helpful for those with certain forms of neck dystonia. There have been some reports for the oromandibular dystonia. People who have generalized dystonia can develop, sometimes they get an infection, they just get completely fixed with dystonia. They go from one crisis of dystonia to the next, and often affects their breathing, end up in ITU. Doctors like calling things in Latin, so it's been referred to as status dystonicus. I think it comes from the old days where if we spoke in Latin, we knew people wouldn't understand us, and that was what we wanted. We're different now. I think we should just say it as it is. So it's a dystonic storm is what we call it now. And they can be rescued by DBS from being in intensive care and sedated. And then other more unusual forms of dystonia can respond. But I think need to be careful. Sorry, I've jumped miles there. Things like the oromandibular, the difficulty with the medical literature is it's the opposite of newspapers. Newspapers love bad news. If you rarely see something, the headline, something really nice happened today. Medical literature is the opposite. You get a good result, you can get it published. So for every one of oromandibular dystonia that had a really good result, there may be 9 unpublished cases that didn't go so well because they don't get published. So you have to be a little bit careful when you just see these single case reports about that. And we did a straw poll of European neurosurgeons a few years ago about this, and it sort of unfortunately confirmed what we as neurologists, who are not very good at surgery, so we're just jealous really, but that actually most of the no results or didn't work never come to light. So you just have to be a bit cautious when you hear about some of these things. What's new and what's interesting? Well, what happens in normal deep brain stimulation is the electrodes are stuck in the head, they're connected to the stimulus generator, and then it just carries on stimulating that bit of brain, and it's a misnomer because it actually doesn't stimulate that bit of the brain, it actually blocks that bit of brain from working. And that's how it has its effect. It interrupts some of these movement pathways. But everyone in this room with dystonia knows that it's never the same each day. There are bad days, there are good days, there are some days when you've got stressed or you've got an infection or you're just fed up. It's a lot worse. So people are now talking about what's called adapted deep brain stimulation. This is coming in now into the field of Parkinson's disease, where dystonia is being used quite a lot, and they're obviously getting the operating theatre ready next door for our next case. and it's just constantly stimulating at the same frequency, the same voltage. What they want to do is have a system where it delivers more of the stimulus when you're bad and maybe pulls back a little bit when you're good. And in Parkinson's, they're beginning to do this because the electrodes can also measure. They can also record the activity which is associated with, in Parkinson's disease, with the tremor and the stiffness. In dystonia, it's a little bit different. And they want to use that to feed back to the stimulator, say, right, you need a bit more oomph now, and then when things are calmer, a bit less. And this may have a better daily sort of variation control. Beginning to come in Parkinson's disease, a little bit further away for dystonia because it's harder to measure whether you're good or bad in that. But this may be developed for the next few years. Now, I was going to put this as the title, rather than saying modern management of DBS, this was going to be my title slide, and I just thought it was a bit too negative. So then the question is, why are we so bad at treating dystonia? And you have to sit back and think, because dystonia is not new. We've been aware of it for a long time. Neurologists have been studying dystonia for a long time. And there are many reasons, I think. And these are the reasons I thought of. One, very few dystonias are the same. It's what we call heterogeneous. We get the focal dystonias, and even within focal dystonia, lots of different types which respond to different drugs and work in different ways. And they are different from the bad, severe, generalized dystonia. So it's quite difficult. There may be many subtypes. If we're honest, we don't really know what's going on to cause these movements. We know the motor pathways, we know bits of the brain, the basal ganglia, the cerebellum, the cortex are involved. Don't really understand quite how it is. We're not very good at measuring it or quantifying it. One of the things you need to do trials in any condition is what we call biomarkers, something you can measure. Then you give them the treatment and you measure it again, and if it's got better, you think, aha, we're doing all right. If it gets worse, you think, oh, well, that didn't go very well. So we haven't really got very good biomarkers for dystonia. These are things which other conditions, not just neurological ones, diabetes, heart disease, you have things you can measure. Big problem, the drug companies aren't really interested in dystonia. It's not common enough because to invest in producing a drug costs a lot of money, so you want a big market at the end of it. Most pharmaceutical trials, if you look at the world of dementia, where there's a huge investment at the moment, most of the trials in Alzheimer's, in fact, all of them actually have failed. And they can cost billions of euros to actually do a full trial all the way through. So when you've got a small audience like dystonia, not so popular. Although the sea is changing now. We're beginning to see biotech companies getting much more interested in rarer diseases. So I'm hoping that may be true. And consequently, of all neurological conditions, there's not much funding in dystonia. So that's the bad news. Things are changing. These are just 2 papers in the last year or so about understanding more. There's a lot of work, and you probably say, why are we always studying this rare genetic dystonia? The answer is because we can be sure that's what they've got. Knowing the gene is there, we know they have that type of dystonia. So you can get quite a clean sample of people knowing they've probably got the same thing going on in their brains. So a lot of the research, and this is one actually from, I think Mark Edwards is involved in this one, who's left the stage now, and the building probably. And he did some work, and they just found they had them doing this task following it. And it's a nice word, a manipulandum. It's a robotic arm, and they do with their own arms some tasks. And they measured various parts of brain activity and found interesting parts of the brain, including the visiomotor, the part in where you integrate what you see with what you do, was quite involved. This could be something you could measure as when it's bad, it means your dystonia is bad. When it's good, your dystonia is not so good. And then there's quite a few across the world. There's a very active group in Rome looking at mouse models of DY21 dystonia, and they're looking at the chemical messengers. And it was last year there was one where they found in their cell models, in their mouse models, that there was a particular receptor, so for dopamine. So this is the chemical messenger, and the receptor is what that locks onto to stimulate the brain cells that seem to be involved in producing the dystonic movements. And when they reversed the problems of that receptor, those got better. So these are just small ways of nibbling at the problem. How do we think we can be clearer? Well, one thing I've got to say, we're doing a little bit of research here, and we're looking at DYT1, and we're growing brains in dishes, sort of. So we're using this, we're getting skin biopsies from people with DY21 dystonia. You grow those skin cells in a dish, then you can treat them with various compounds and turn them into stem cells, which are what embryos are made up of. And then you can do a bit of cookery and put a bit of a cocktail, and you can turn them into brain cells in a dish. And then you can study the disease, what's going on in those brain cells. And that may give you an idea what can happen. And this is just some work that I won't embarrass her by getting started, but one of Nuria, who's a postdoc working with us, is in the audience here. She's doing this work because she's good at cooking these things. And what we're looking at is what's called the transcriptome. And this is a piece of research which is often done by drug companies when they're trying to find targets for something. The transcriptome is when your genetic codes turn into a protein, it goes through transcripts. And these get regulated and varied, and you often see they differ in different conditions. So what she's doing is she's growing up little different types of brain cells in dishes. It sounds easy, it's not as easy as it sounds. And then she's taking out these transcripts and we're going to be analyzing them, and you can see patterns. You can see which transcripts go up, which go down, and they will tell you which pathways within those brain cells are being affected. And that's one way of finding something that may tell you what's going on, but more importantly, something you can manipulate. And as well as doing that in our models in dishes, we have got some brains of people who had this type of dystonia and very kindly donated their brains for research after they died around the world. And if we find what we're going to call a dystonic signature in these, we're going to study it in the brain tissue from these to say, is that what we find in real human brains rather than things growing in a dish? And then the really cool thing would be to say, does this signature, if we did the same sort of cookery in dishes, is that what you see in cervical dystonia, writer's cramp? So this is work that's going on. Don't know the answer because we haven't got to the bottom of it. Another way of looking at it, and we're still after people with DY21 dystonia who may want to give a bit of skin for research. It's not a major operation. Everyone survived so far, so it's just a bit of a local anaesthetic, and we take a skin. So particularly within the UK, it's not so good shipping them from Europe. So if anyone knows, we might be looking for that. So we said why we're not doing very well at getting answers to dystonia. This is my blueprint for how we might get better. And this is learning from other conditions. So it's learning from all the money that's been thrown into dementia, and certainly in the UK in the last 10 years. How have they tackled these difficult problems? And the thing to do is to get together groups of patients who've got, as far as we can tell, the very, very same type of dystonia. And what we're looking for is patterns in them which will be relevant to the other forms of dystonia. So it's something we're beginning to do at the UCL Movement Disorder Centre and other places around Europe, is we want to get together a nice little cohort of patients who've got DYT1, a nice cohort of patients who've got cervical dystonia, and probably writer's cramp as well. We're at the moment recruiting for our own patients, but we'll be looking for others in the future. We want to know their whole history. We want to know everything that's happened to them throughout their life, because that's really important. We can then study these to try and identify these biomarkers, something which may be a chemical in their blood, their urine, or even their spinal fluid, that matches when dystonia is good and when it's bad. One of the other things we'd really love to know, which I think is key, is a lot of people who have genetic dystonia have the bad gene and never develop dystonia. So they've got the gene we know causes it. What would be really interesting is what's different about them from their brother who has that gene, exactly the same gene problem, and gets dystonia. That must be telling us ways we can deal with dystonia. So we want to get these. We can look at so-called wet biomarkers, thing in blood, urine. I think there is more work that needs to be done doing the sort of work that Anne spoke about, looking at the pathways, and there's newer technology coming in that we can do that. And the whole point is to find something different in people with dystonia as opposed to people who don't have it. Because as soon as you've got that, it's not rocket science. Pharmaceutical companies are then interested because you've done most of the hard work. And so what's happening often, universities, academics are trying to get to this stage, and then interesting the people who've got these huge libraries of hundreds of thousands of molecules which you can then throw at this and say, does it make any difference? So that's what we're trying to do, and that sometimes brings the money into it. So I have finished. He stood up. Clearly I've lied and I've gone over time. Lots of people to thank. Over the years, I've been involved with the Dystonia Society since 1991. And Dystonia Europe, not quite as long, but they haven't shaken me off yet. So there are lots of very important people who've helped. Help isn't always money. Help's just finding people to help with our studies, patients who want to get involved. And then my colleagues who I work with at UCL Movement Disorder Centre, these are the clinicians who give patients and help. And at the risk of being bombarded, that's my email if any patients in the UK, particularly with DYT1, are interested. drop me a line, I won't be rude. So thanks very much for listening, and I'll be quiet.
Thank you. Thank you very much, Tom. Just to say thank you for being able to give us bad news with a sense of humour. I'd like you to be my doctor, because then I know that it will make it less painful. Maybe time for just one or two questions, particularly if you've got an idea for the treatment of dystonia or the management, that would be helpful. Yes, over there and over here.
Ian Boddington. I've had DY21 dystonia, which I onset at the age of 13. I'm now in my upper 50s. When I was in my early 30s, I got a remission, which lasted nearly 4 years, which was wonderful. I think about 10% or more of people with dystonia get a remission of some sort. I know a lady in our London group who's been in remission for over 20 years. Sure, this is something that needs to be looked into carefully, because as remissions often do occur, people with dystonia, perhaps they could actually be induced. Thank you.
Excellent question.
A very good question. It sort of asks the same questions, but you did it in a much better way than I did, about what does sleep do, what do people who who've got the gene don't get it. Yes, you're right. Of all forms of dystonia, we say it's about 10% have remission. Sadly, most of them get the dystonia coming back again, I think you said, but 4 years was quite a good innings. It's often shorter than that. And then you said some don't. So I think undoubtedly we should be learning. The difficult thing is what questions do we ask, but that should never stop us asking. So I take that as a very good point. And sometimes just looking at people's life history, what's happened to them, very simple type of research, it's not very clever, can be quite productive. So very much take your point.
There's a question at the front here, and a question at the back.
I don't know if this is working. Yes. I've got a question and a comment, and it's about intrathecal baclofen. And my son, who's got extremely severe spasms in his back and his trunk, had a really strong dose as a trial for intrathecal baclofen. And we joked, was it water? Because it had absolutely no effect. Now, the consultant said, oh, the dystonics, they're the weird and wonderful group. But I was really interested as a biochemist, because he said this would fell a horse, and it did nothing to my son. So I was just thinking, actually, when you have a negative result, that might actually tell you more about the mechanism of the body spasms than, sort of a good result. And I just want to mention one other thing, and that's I've read recently about a biomechanical aspect to dystonia. And my son has TMD, with a TMJ, and he tried a device to help him with his jaw, and it did reduce his spasms. So maybe the squeezing of the cranial nerves had some effect. I don't know. All I do know, and I just would value your comment on how you could have somebody with a huge dose of baclofen intrathecally having absolutely no effect on their muscle spasms.
That's my favourite type of question, because I can say, I know someone standing about 5 metres from me who knows far more about intrathecal baclofen than I, and I'm going to ask Jean-Pierre to say what he... I probably have had 1 or 2 patients with it, because I'm an adult neurologist, and it's used much more in paediatric practice. I don't know what your thoughts are.
Yeah, well, actually, there's just been a paper published in Annals of Neurology that says that children, young people with severe dystonia do benefit from intrathecal baclofen. However, of course, this is a very short-term study, and in a lot of studies that report, 1-year results, double-blind, placebo-controlled, we don't know what it's going to be like, a few years down the line. But I think our experience with this issue of the single injection is that it has led to the practice of putting in a small catheter and then putting in an infusion. So if you get a negative result after what seems like, big dose, single dose, it's not a satisfactory trial, and having, if you like, a short-term infusion over several days might give you a more appropriate answer. So I think that is the way to be absolutely certain that ITB might not be useful. My own personal worry about ITB is that it is good for a relatively short period and sometimes can become a problem, the symptoms seem to rebel against the ITB. Somehow the dystonia finds a way around, and I think this is a tolerance to the medication or tachyphylaxis can be an issue.
I think actually what's very simple is because it's the same with the medication. The levels of anticholinergic drugs that kids can take and can tolerate would fell almost all of us in this room. So there is something that they tolerate or don't react. Or
but they can't think. That's
yeah.
the problem. Their dystonia might improve, but they're in a fog. And so this is why the parents report the side effects. There's a question at the back. I think we should try and get that in.
My question was about TMJ and its association with dystonia, and whether or not there's been any studies done in this country on TMJ.
You've got a very low voice, and we can't
okay.
need a higher frequency.
I'm just curious about TMJ and its association with dystonia.
Temporomandibular joint.
Yeah.
Yeah.
Yes, I mean, there's TMJ dysfunction is very common. I think you can see I'm flanneling because I don't know the answer to this question. It's people get spasm, they get a lot of pain from the TMJ. As a trigger is it as a trigger for dystonia or as part of dystonia? Is that nodding for trigger?
I'm curious because my dystonia started about 11. About that time, I also had some dental surgery to push out my push back my teeth. I'm kind of wondering about if there is an association. I think in America they've done some studies on that.
Yeah, so yes, I mean certainly people who develop dystonia, which can affect the jaw, the mouth, tongue, and there is certainly some evidence that trauma, and dentists won't like me saying this, but dentists are traumatologists, they produce trauma in your mouth, can induce dystonia in certain people. So for some of the other forms, the trauma to a limb has been associated with developing dystonia, and it then spreads. So I'm not sure, I think that may be more of a reflection, it may not be as specific for dental work, but trauma can seem to induce dystonia, probably in people who are susceptible to getting it in that region, but then it can spread. Again, it's part of the wonderful world of dystonia that we don't understand why that happens.
Just an observation from my point of view, obviously the temporomandibular joint, can you live without eating and chewing? And the answer is probably not. So it must be one part of the motor system that is used to excess. And chopping and grinding and all the rest of it, it must be a furiously active process. And I don't know whether it's the overuse of our jaws that predisposes us to get, TMJ, dystonia.
So if something happens to alter the structure so that each time you chew, there's a continual trauma, maybe that would be quite damaging.
It's possible, yes. I mean, I think you can tell there's a certain lack of knowledge up on the platform at the moment.
Yeah, definitely. So thank you very much, Tom. Now we're going to